who is teachers of teachers, I always say, and he has taught pediatric advanced life support courses not only in Delhi, I think across India. He may have conducted more than 100 courses actually. That is his dedication. And even myself has done a PALS course under him, and he was the one who motivated me to do instructor course. And after that, I also started doing PALS courses. And myself, Dr. Suresh Gupta, I am the co-chairman of Department of Pediatrics and co-director of Pediatric Emergency Intensive Care Pathology at Sir Gangaram Hospital. So today, Dr. Rishabh Jain, who is second year DNB student in our department, will be presenting an interesting case. So now I hand over the mic to Dr. Rishabh.
Yes, sir.
So Rishabh, you can start the case.
Yes, sir. Good evening,
Dr.
everyone.
You want to say something in the beginning, or we can start the case?
Yeah, we should start the case, sir.
Okay. Thank you, sir. I'll start the case. Presenting a case of a 2-year-old male child coming from Buradi, from Delhi. Informant is mother being reliable. The child was received in the emergency emergency, and the date of examination was 28th of May, 2024. The child came to us with the chief complaints of vomiting for the last 3 days, complaints of loose motion for the past 2 days, and complaints of rash all over the body for the past 1 day. Coming to history of presenting illness, the child was well 7 days back when he had a fall in the bathroom with impact over the posterior aspect of his head. The child remained well and no treatment was taken. The child again had trauma 3 days back when the child was playing and hit his head on the wall. It was not associated with any history of loss of consciousness or any seizures. At that time, the child was taken to emergency, where some sutures were applied to the laceration that was present over the scalp. Following this, the child had started complaining of vomiting for the last 3 days. It is usually like 10 to 12 episodes per day. The vomiting was yellow in color. It was watery in consistency. It was non-mucoid and it was not non-blood tinged. The child also started complaining of loose motion, which happened for the last 2 days. It was around 4 to 5 episodes per day. It was again watery in consistency. It was yellow in color. It was non-mucoid and it was non-blood tinged. The child then presented to us with the complaints of rash for the last 1 day. It was erythematous or red color, and it was confluent rash that started on the face and progressed over to involve the trunk and the upper limbs. These rashes were not associated with any itching. The treatment history, the child was admitted in an outside hospital from 24th to 27th of May with the above complaints. With the above complaints, at the hospital, CT scan was done, which showed a scalp hematoma that was present over the left parietal region. No operative procedure was done for the same, and supportive treatment was done. And the child was started on IV antibiotics for the vomiting and the diarrhea part. On investigating, the child had a high TLC count as per the parents, and also there was an episode of altered sensorium next day of admission, for which the child's antibiotics were upgraded. Child sensorium improved, but the child had persistent irritability, and for that the child was referred to Gangaram for further management. Actually, during the course of this admission only, the child had developed the rash, and the child developed rash while the child was being shifted to Gangaram. Coming to the negative history, so there was history of vomiting, loose motion, and rash, but there was no associated history of any fever. There was no history of any seizures, loss of consciousness, or head banging. Since the child had a history of fall, I had asked for these symptoms. There was no history of any sore throat or cough, since a streptococcal infection can present with the vomiting, diarrhea, and associated with rash. So I have asked for the sore throat or a cough part. There was no history of any blisters before the rash or any itching for any staphylococcal infection causing these symptoms. There was no history of any joint pain or swelling. This I have asked to rule out any rheumatological cause for the rash thing. but since there was no history of fever also, that also goes against it. There was no history of any travel or any insect bite. There was no history of any recent vaccination, and there was no history of any eczema or blood in the stools. This I was asked to rule out any cow milk allergy that uh, could be one of the possible things in this case. Oh, so should I continue?
Yes, complete your history first.
Yes, sir. Okay, sir. Coming to the past history, there was no history of any similar complaints in the past. Before this, there was no history of any admission in the healthcare setting. In the family history, there was no history of any similar complaints, and there is also no history of any allergy in the family. Coming to the pedigree chart, the child was the only child that and it was a product of a non-consanguineous marriage. Coming to the birth history, antenatal history was supervised. The mother has received 2 doses of TT and had received iron and folic acid supplements. Coming to the natal and postnatal history, the child was a full term delivered by LSCS in view of non-progression of labor. The child's weight was 3 kg at birth. There was no respiratory distress, cyanosis, jaundice, or seizures that was after the delivery. Breastfeeding was initiated within half an hour, and the child was exclusively breastfed up to 6 months. There was no feeding difficulties or hospitalization, and there was no history of any poor weight gain. Coming to immunization history, the child was immunized up to date as per the parents, but there were no documented documents that were presented. The child had a BCG scar that was present on the left shoulder. Developmental history, the child was currently, the milestones were attained appropriate for the age as per the history by the parents. Coming to the dietary history, using the 24 hours dietary recall method before the illness, the child was consuming around 1200 kilocalories. And the child was consuming around, sorry, sir, I got it wrong. The child was consuming around 1000 kilocalories and 12 grams of proteins. The child had a deficit of around 8% and 6% of proteins and calories. Coming to the socio-economic history, the family resides in a Pakka house. There are 5 people that are residing in the same house. They have 2 rooms with a separate kitchen and toilet. There was no overcrowding. The house has a good ventilation. The father's occupation is a shop owner. He has studied up to 12th, and the total per capita income is around 1 lakh per month. And they belong to an upper middle class according to the modified Kupuswamy classification. Coming to the summary after my history, a 2-year male child came with the complaints of vomiting, loose motion, and rash, with a history of falls that was 1 week and 3 days back. There was no history of any fever associated. Child was admitted outside for 3 days in a local hospital where the child was evaluated. CT head done was normal, was showing a little scalp hematoma with a raised PLC count. The child was started on IV antibiotics. The child had an episode of altered sensorium. And the immunization history, developmental history, and family history are normal as per the history given by the parents.
Okay. Dr. Rishabh,
sir.
what do you conclude out of this summary? What do you think the diagnosis, what do you think the problem is in this particular child? Because what you say is this child had 2 episodes of fall in the bathroom, and
Yes,
he had stuck his head against the bathroom. And the second time, there was a lacerated wound which required some stitching. And after that, this child had started developing vomitings and altered sensorium. And after
yes.
starting treatment, he developed loose motions also. You have not mentioned anything about the urine output. What was the status of hydration? Because if he's vomiting 10 to 12 times per day, and his vomiting is not settling despite being in the hospital, what was his urinary status? What was his hydration? We have no information about that in the history. And what do you conclude out of your history as what is the probable cause? What are the differential possibilities at this stage?
Yes, sir. Sir, based on the history, sir, first we have to rule out for any uh, uh, raised ICP that could be seen in this because the child had a history of 2 falls and then he had loose motion and vomiting, sir. But sir,
So was a loose motion preceded by the vomitings, or vice versa? Was the vomiting first event and the loose motion followed? And but this point was not very clear to me.
No, sir. First the vomiting happened and then the loose motion started.
So after the head injury, laceration wound was sutured, and after that there was altered sensorium with vomiting, and the loose motions followed after that. So what is the quality of loose motions? Was it small, frequent amounts, which we see like an antibiotic-induced diarrhea, or it is a profuse watery diarrhea, or you already mentioned there was no blood in the stools.
Yes, sir.
So
No,
we
sir.
need
It
to
was a
understand
profuse
that
water.
part also.
Yes, sir. Sorry, sir. Sir, it was a profuse watery diarrhea, sir. It was more of an infective diarrhea than.
Okay, so you mean to say this was not related to the head injury part? Diarrhea occurred because you cannot explain loose motions by just simple head injury, can
Yes,
you?
sir. Yes, sir.
So you're suggesting two independent events occurring.
Yes, sir.
Okay, in the history, in the dietary history, you have not mentioned whether this child is bottle fed or not. He's just 2 years old. You have though you have mentioned about the protein deficiency and the caloric deficiency, but you have not mentioned about the feeding habits of the child. How is the child feeding? Whether he is a bottle fed child, how many times he takes the milk, whether he is good in complementary feeding is adequate or not.
Yeah. Yes, sir. Sir, the child was only completely breastfed till 6 months. After that, they have started complementary feeding for him. The child takes like 3 times in a day. They give him milk, sir. And apart from that, they give him complementary feed, sir. They have started.
That's bottle fed.
Yes, sir. That was bottle fed, sir.
So that may be the source of infection for the intestinal problems.
Yes, sir.
Okay, okay. So what was the hydration? How was the urine output at this child of this child?
Sir, when the child was in the other hospital, like the local hospital, at that time the urine output was good, sir. And the child sensorium at the time of admission also they said that it was good, sir. There was just one episode of altered sensorium, but that also at that time also the urine output was good, sir. But uh, they have never mentioned that there was decreased
So
urine
if the
output.
child is having so much of urine output despite so many vomitings and head injury, does that strike you something?
Sir, it could be cerebral salt wasting, uh,
Yeah.
uh, but
We need to, so that's why we need to understand what is the urine output in such a situation, right?
yes,
This is a
sir.
very important parameter, clinical clue to start thinking in those lines also.
Yes, sir.
Okay. What was the nature of the rash? You just said it was erythematous rash. So was the skin, edematous, doughy, or it was maculopapular, or there were vesicles or pustules, or what was the things?
Sir, the rash that was the maculopapular rash, sir. And when the child came to us, sir, there was also edema of the hands that was
So we
present,
will
sir.
we'll come to the
Yes, sir.
examination part. Here we are
Yes,
just
sir.
talking about the history. So
History.
no vesicles, no pustules reported in the history. It
Yes,
was
sir.
only redness which was reported, and there were patchy areas of redness, which that is what you are suggesting when you say maculopapular rashes.
Yes, sir.
Okay, right. So right. So any locomotor abnormalities before he went into those the altered sensorium state? Was he able to walk? Did he have any leg pain, leg joint pains, or joint swellings, or anything of that sort?
No, sir.
Because he
There
had a
was.
fall twice,
Yes, sir.
so he had vomitings also. So I'm just considering, did he have any other area of impact or injury, or did he injure himself anywhere else also other than the head scalp?
No, sir. Actually, sir, the second time he didn't fell. Like he just hit his head on the back of the wall, sir. So there was no history of fall, but he had hit his head on the back of the wall, sir. Uh, but there was no other injury of any other than the head part, sir. The child was walking fine as per the parents, sir.
So that also reminds me of two things that one, the child is having repeated falls. A 2-year-old child who is otherwise what you have mentioned in the developmental history and the birth history is not nothing is contributory, but this child is now falling twice, and whether there is any regression of milestones or whether there is any gait abnormality. What you have mentioned in your history is the development was essentially normal. So why I presume that his motor milestones and everything are preserved and they are normal and appropriate to the age.
Yes, sir.
Okay, Okay. Chalo, let's proceed with the history, with the examination. Dr. Suresh, if you have to add anything to what I've already discussed.
Dr. Taneja, I think you have covered almost everything which is important from history point of view, and generally which is asked in uh, examination also.
Right. So let's go to the examination and then see what we find next.
Yes. So, coming to the general physical examination, after introducing myself to the parents and taking the parental consent, the child was examining the lying down position. The procedure involved were explained to the parents. At the time of examination in the ER, the child was conscious. He was alert, but the child was very irritable and was uncooperative. The vitals that was measured, temperature was of 98.6 degree. That was measured with a digital thermometer in the axilla. Pulse was 154. It was regular and it was good volume at the time the child was in ER. There was no radial delay. All peripheral pulses were felt. Uh, and the respiratory rate was 50 and it was thoracic type. The blood pressure but the child was irritable at that time. So the blood pressure that was measured were around 80 by 45. It was a non-invasive blood pressure that was measured in the right arm in the sitting position, and that was around 50th to 90th centile. The saturation at the time was 98% at room air with the capillary filling time of less than 3 seconds. On examination, there was pallor present, but there was no icterus clubbing cyanosis. Sorry, edema was present, and there was also no lymphadenopathy.
So edema was present.
Yes, sir. Yes, sir. Edema was present, sir.
So where was this edema, in the legs or somewhere else, or the
Sir,
sacral area?
Sir, it was present on the dorsum of the hands and the legs, sir, and the ankles.
Okay.
Yes, sir.
Okay. So was it secondary to the IV infusions or extravasations, or it was actually edema?
No, sir, it was actually edema, sir. I'll come to that in the head-to-toe examination, sir. Yes. Coming to the anthropometry, the child's weight was 10 kg. Expected for him was 12 kg. It's coming
Dr.
between.
Rishabh, can you go to the past slide?
Yes, sir. Sorry, sir.
Okay. So on one hand, you are telling us that this child is conscious, alert, irritable, and uncooperative. And on the other hand, you are telling us that you are able to measure the blood pressure in right arm in a sitting position. These two things doesn't go hand in hand unless
Yes,
there is a lot of time gap between examination to examination.
yes, sir. So the child was irritable. Yes, sir.
So in such a child, it may be difficult to say, because in exam this can be an issue actually, because this child is admitted in ward. It's possible that you check the BP previous night, right? But in examination, you get only 30 minutes. And if the child is irritable, then you cannot write like this. Then you have to
Yeah.
actually mention that I was not able to measure the blood pressure because child was not allowing or something.
Okay, sir.
Is that right, Dr. Neja?
Absolutely right. Being honest is the best thing. But you have to actually admit that this child was not cooperative and he was not allowing you to examine. So that is much better than writing a false reading over there.
Okay, sir. Sorry, sir. Sir, coming to the anthropometry, the child's weight observed was 10 kg, and the expected for him was 12 kg, which was coming between 25th to 50th centile. The height of the child was 88 centimeter, and the expected is 87 centimeter, and it was also coming between 50th to 75th centile. Coming to the head-to-toe examination, on head-to-toe examination, pallor was present. In the scalp, as we saw, there were sutures that were present with a mild swelling in the left parietal region. On examination of the face, there was congestion that was present in bilateral eyes. On the lips, there was dry crusted lips that were present. And there was also maculopapular rash that was present on the face and the trunk. And it was a maculopapular rash and it was blanchable. And on the hands, as we can see, there was edema that was present on the dorsum of the hands. The spine observed was normal, and also the genitalia was normal. but the edema was also present on the dorsum of the ankle on examination.
Okay.
Coming to the systemic examination, first coming to the per abdominal examination. On inspection, the child's abdomen shape appears normal, the flanks appears normal. Umbilical position was in center and with no discharge. Umbilical appears normal. Abdominal movements, since the child was irritable, the movements were, I could not assess it properly. There were no skin over the abdomen appears normal. There were no swelling seen. Hernial orifices appears normal, and genitalia also appeared normal. Coming to palpation, it was done in child in the lying down position with legs flexed, with both hip joints flexed at both hip joints and knee joints. The abdomen feels soft on
Dr.
palpation.
Rishabh,
Yes, sir.
when you say abdominal shape is normal, what do you mean by abnormal shape? In abdomen?
Sir, abdominal, sir,
What
if
is
there is
normal?
a,
What is abnormal?
yes, sir. Sir, there could be a scaphoid abdomen, sir, or there could be, if there is any singular mass that could be protruding on one side, or if there is lax muscles, sir. Uh, um,
Okay.
yes, sir.
कैसे बात कर रहे हैं?
Continue.
Yes, sir. So on palpation, that was done in the child in the lying down position with legs flexed at both hip and knee joint. The abdomen feels soft on palpation. There was no tenderness, guarding, or rigidity that could be felt, but the child was still like irritable when I was doing the examination. So I could not assess it properly. There was on deep palpation, liver was felt 3 centimeter below the right costal margin. The spleen was not palpable. On percussion, a resonant note were heard. On auscultation, bowel sounds were heard normally. Coming to the CNS examination after that, the sensorium on examination appeared normal, but the child was irritable during the examination. The tone was normal in all the 4 limbs, and the child was moving all the 4 limbs equally, so the power could be assessed at more than 3/5 in all the 4 limbs. The deep tendon reflexes that were done were +2. And coming to the cardiovascular system examination, there were no prominent veins or visible pulsation that were seen in the pre-recording. S1, S2 was heard normally, and there was no murmur or any gallop. On respiratory system examination, child had tachypnea. There were nasal flaring that was present, but on auscultation, there was bilateral air entry present that was equal, and there were no added sounds as such. So coming to my summary after my history and examination, 2-year-old male child coming to us with the complaints of vomiting, loose motion, and rash, with a history of fall 7 days back, and within 1 episode of altered sensorium. On examination, child had tachypnea with nasal flaring, with confluent maculopapular rash that was present over the face and trunk, with dry crusted lips, with edema over the hands and feet, with otherwise normal systemic examination.
So, Dr. Rishabh,
Yes, sir.
this episode of altered sensorium, I'm not getting exactly what exactly happened. Because in the history, you mentioned the child was in altered sensorium and vomiting, and then he was subjected to some imaging, neuroimaging, and then he was referred to your hospital. So, at the time of arrival, this child was conscious, he was irritable, he
Yes.
was not allowing you examination. But what was the level of alteration of sensorium? Was it a temporary, brief episode, or it was a persistent? The status which the child presented to you was labeled as altered sensorium.
No, sir, it was a brief episode that happened in the other hospital, sir. And that also improved, but the child still remained irritable only, sir. So with irritability, they referred us
So
to
that
the...
alteration of sensorium, what was the precipitating event? Was it a seizure, or what was that which made the child altered in sensorium?
Sir, no, sir, there was no seizure, sir, but the child had persistent vomiting. So, sir, maybe
I think there are certain gaps in this particular information.
Yes.
Anyways, koi baat nahi, let us proceed further because we need to be very sure what we are talking about. If we say altered sensorium and then the child is coming to us and we don't have any information, what was the status before, why we said altered sensorium at that time, what was the precipitating event, whether it was seizure, whether it was fever, what was labeled as altered sensorium, वो details नहीं है हमारे पास इसके अंदर.
Yes. Yes, sir. Sorry, sir.
ठीक है, चलिए आगे चलिए.
Yes, sir. So based on my history and examination, sir, the diagnosis, the provisional diagnosis that I shall keep is first, I'll take it as initially with the sepsis, with the rash. Second, since the child had the history of vomiting, loose motion, and he had a very particular features of maculopapular rash with dry crusted lips and edema over the dorsum of hands. I would like to keep second as toxic shock syndrome. And third is since the child had congestion in both the eyes also, and there was edema of dorsum of hands and feet. But there was no fever, but still I would keep an atypical Kawasaki as my third differential, sir. And fourth is, sir, maybe at the other hospital, the child had received certain antibiotics, which could have caused the precipitation of the rash. And the child now presented to us with that rash. So fourth, I'll keep it as a drug-induced rash with sepsis that the child presented to us.
Okay, let us discuss one by one whatever you have said. Why do you say the child is in shock?
Sir, the child was tachypneic and irritable, sir, and there was no, though the pulses were good, sir, and the peripheries were warm, sir, but sir, the child was still very sick looking on overall examination, sir. And,
if you say the shock, if you say the child is in shock, you should have compromise with the cardiovascular system or the circulatory insufficiency. Features of circulatory insufficiency should be there,
yes,
right?
sir.
You may say the child is in normotensive shock because the blood pressure, what you have said, is 50 to 90 centile. This is
Yes.
normotensive. This is not hypotension for this particular age, right?
Yes.
So he may be in normotensive shock. So with shock, you say tachycardia is there, tachypnea is there. These are two non-specific features. But what rhythm you said, it was regular rhythm, that it is regular there. So pulse volume, you said good volume pulse. Capillary refill time, you say it is less than 3 seconds. Then where is the shock? All the parameters, see, only on tachycardia and tachypnea, you want to label this child as shock. So you should have more evidences. These are very, very non-specific parameters. Tachypnea and tachycardia can happen just by the child visiting. You said the child is uncooperative, he is irritable. So that can also cause tachycardia and tachypnea.
Yes, sir.
Right?
Yes,
So
sir.
for you to label this child as shock, you should have parameters of shock which are demonstrable. If you don't have demonstrable parameters of shock, then labeling the patient as shock is going to put you in trouble.
Okay, sir.
Then, okay, why septic?
Sir, maybe when the child presented to another hospital, because the child started receiving antibiotics, the fever got masked, sir. And
Was he on round-the-clock paracetamol or
yes, sir.
antipyretics without recording of temperatures?
No, sir. The child was
Why
not
should
on.
the see,
Yes, sir.
even when these children come to us in septic shock, even when we give them round the clock paracetamol, the fever spikes do appear in between, and we come to know that the fever is persisting. है ना? Mothers आके कहती है, सर इसको फिर fever हो गया, फिर इसको fever हो गया. That fever cannot be suppressed unless you give blatant use of antipyretics, multiple antipyretics round the clock, and not bother to measure the temperature. if that is the status, then you may say if the fever has been missed. But there is no history of fever. The parents have not recorded any fever. The parents have not reported any fever, and you have not reported fever anywhere during the story, during the history which you have told us. And also during the examination, you have mentioned child is afebrile.
Yes.
So, where does this septic and the shock? See, when you speak certain things as a doctor, whenever you speak something, it should carry some weightage and some evidences. Without evidence or without any proofs, if you make a statement, then you are undermining your own status also,
Yes, sir.
right? So, as a postgraduate pediatrician, you have to be dogmatic. You have to be clear in your concepts, what you are speaking and why you are labeling those things. तो आपके तो
Yes.
फर्स्ट डायग्नोसिस के अंदर आप जस्टिफाई कैसे करोगे कि सेप्टिक भी है और शॉक भी है?
Yes, sir.
Rishabh,
Kawasaki disease, again, there is no fever.
Fever. Yes.
Toxic shock syndrome, a child is irritable. Okay, that can be explained because pain the child would not complain of. 2 years old child doesn't complain of pain. So he will remain irritable and uncooperative. That is okay कि उसको body aches हो रहे हैं, गर्दन में दर्द हो रहा है, उसको कहीं body में दर्द हो रहा है, and he is not able to communicate properly because he is just 2 year old. 4 साल से पहले बच्चा पेन को लोकलाइज नहीं करता, बोलता नहीं है, वो रोता रहता है सिर्फ. तो वो आप मान सकते हैं कि उसको पेन हो रहा है और उसको साथ में उसको रैशेस आ गए, और जो सूचर लाइन के आसपास भी आपको एडिमा मिला और जगह पर एडिमा मिल रहा है, आपको हैंड्स एंड फीट पे एडिमा मिल रहा है और रैशेस मिल रहे हैं. दैट इज ओके, मतलब वन कैन स्टार्ट थिंकिंग इन दैट टर्म, बट देन अगेन द $1 million क्वेश्चन रिमेन्स, वेयर इज द फीवर?
Yes, sir. Yes, sir. So fever, but sir, streptococcal toxic shock syndrome.
What about we discussed raised ICP in the first
History.
differential diagnosis when we were talking about the history. If
Yes,
we
sir.
talk about raised ICP because of after fall, उसको vomitings हो रही हैं, irritable हो रहा है. So, was there any evidence of neck rigidity or Brudzinski sign or Kernick sign or
No, sir.
neck stiffness?
No meningeal signs could be identified in the child. Sir.
What about the fundal examination?
Sir, fundal examination was normal, sir. I have written in the further slides.
Okay, I probably missed that. Right, over to you, Dr. Suresh. Can carry forward with your comments.
Rishabh,
Yes, sir.
can you just in brief tell us what are the signs and symptoms of shock?
Yes, sir. So the signs and symptoms of shock that will, sir, first the symptoms, the child will come lethargic, or the child will be could be irritable or lethargic, sir. And when the child comes to us, sir, on looking, the child will be sick looking, sir. And the child, sir, on signs that could be seen in a child with shock, sir. First, sir, sir, the child will be tachycardic, sir. Then the peripheries will be cold in case of the peripheries will not be warm, sir. Only in case of septic shock it would be warm, sir. And the child can have tachypnea, sir. Then, sir, the CRT, sir, the capillary refilling time will be prolonged, sir. The urine output will be less in case of a child. The child is presenting with shock, sir. And sir, the urine output will be low. Pulses. And
So you have to look into the effects of circulation. Circulation के effects क्या क्या होते हैं? Circulation का effect होता है pulse generate करना, तो pulse volume कैसी है ना? Capillary refill time produce करता है, skin color and temperature produce करता है circulation. So that is the area that you have to observe कि ठीक है, यहाँ तक blood आ रहा है, यहाँ तक flow हो रहा है, यहाँ तक उसका जो है circulation improved है. तो जहाँ circulation compromise होगा वहाँ आप shock होगे. चलो आपकी बात हम ये भी मानते हैं कि maybe this child was in a hospital setting. So the setting of shock, if you look at it, is more likely to be a hypovolemic state when the child has presented to you with multiple vomitings and poor oral intake. But then at the same time, you told us in the history also that the child was passing good amount of urine. So that hypovolemia has been taken care of. Then why this child is in shock without any fever? Are we dealing with a cardiogenic shock? So that is something which strikes my mind instead of septic shock and the other things.
Yes, sir.
Over to you, Dr. Suresh.
So as Dr. Taneja explained actually, sometime unless there is a very obvious cause of shock, we may call it undifferentiated shock. Right? Shock is there, but we are not sure about the cause, whether it's septic or cardiogenic. And unless a hypovolemic shock, then we are very clear actually. There is a strong history of loose motion and vomiting or blood loss or burns. In this case, we know there is setting. But when these things are not there, sometimes it may be not possible to say just on clinical examination on in many cases what is the cause of shock. Right? So you may have really look further into, right? So though clinical examination can give you the clue, some of the clue, let's say cardiogenic shock or septic shock. Then we have to look all the parameters. And as Dr. Taneja told, okay, this diagnosis of shock, right? He always teaches that there are 3 or 4 organs whose circulation can be assessed clinically, right? Skin. In skin, because when the skin is getting less perfused, what happens? It
Yes,
becomes
sir.
pale, it
Yes.
becomes cold. And because of increased sympathetic activity, there is a more sweating, right? The skin color can be mottled also. And decreased skin perfusion leads to increased capillary refill time.
Yes, sir.
Right? For kidney, when the kidney are getting less perfused, urine output will reduce actually. So you can ask how many times the child urine passed. Though urine which the child passes immediately in ER may not be good indicator to tell that kidney is properly perfused. And same way, CNS perfusion, any alteration sensorium may be one of the indicator that cerebral perfusion is affected. So, so these are the 3 organs which can be assessed clinically, in addition to hemodynamic effects, which he explained in terms of tachycardia, fast feeble pulse, or low volume pulse, and later on decreased blood pressure. So one has to tell all these parameters when somebody asks you what are the clinical signs and symptoms of shock, which indicate shock.
Yes.
ठीक है, Dr. Rishabh, when do you make a diagnosis of Kawasaki's disease? What are the clinical criteria for making a diagnosis of Kawasaki's disease?
Yes, sir. Sir, first, the child should present with a history of fever for the last 5 days, along with any.
Yeah. The first statement is 5 days of unremitting fever, almost continuous fever, irritability, and then you have all those parameters where you have conjunctivitis and non-purulent conjunctivitis and edema feet and cheilitis and glossitis and other parameters, joint involvements and other things. So आपका first criteria fulfill नहीं होता है इसके अंदर, though you have many other signs which may be overlapping with Kawasaki-like condition. But the story of 7 days and fall and injury and all those things and without fever, ठीक है, आपने एक एक्सरसाइज क्लिनिकल एक्सरसाइज करने के लिए कावासाकी को उसमें बीच में डाल दिया, तो एक अपॉर्चुनिटी मिल गई कावासाकी को डिस्कस करने के लिए. That's okay for revisionary purposes, but practically, I don't think so. This should be one of the things. So drug-induced rashes. So any drug can cause any rashes in any of the child, and it can cause hypoperfusion also, and it cause vasodilatation also, and it can cause all those parameters. Vasodilatory shock can give rise to, good volume pulse and good urine output and good heart rate, tachycardia and tachypnea, and all those parameters would be there in a vasodilatory state. So that's there. The blood pressure is also 80 by 45. 45 is towards the lower side of the diastolic in this particular age group. So it's a vasodilatory state, which I would say, uh, although whatever the reason might have been, the child has received of some IV fluid, so all the parameters are now masked. So we are not getting the exact parameters which should have been
Yes.
there. But as Dr. Suresh rightly pointed out, we call this as an undifferentiated shock. Probably this is a vasodilatory situation. So vasodilatory situation can happen in toxic shock syndrome. It can happen in drug-induced rashes, and vasodilatation can occur in drug-induced rashes, drug-induced allergic reactions. Septic shock, I would not consider as high up. I would consider it as a low down, because the child, which is this infection which is not causing fever. So that strikes me again and again. Had the fever been there, okay, this is there. This is number one possibility. So coming to toxic shock syndrome, we have all the settings of toxic shock syndrome over here. We have a punctured wound, which was lacerated wound, which was sutured, which was given some antibiotics, some treatment was given. This was 3 days back, a very short history, after which the child developed all these symptoms, and he went on to altered sensorium also. And probably it was a hypertensive episode at that particular time, which was managed in that. I'm presuming things now. So it was managed by IV fluids, and the sensorium recovered after that. And now he has come to you with irritability, because the hemodynamics have been probably addressed in the previous hospital. Now it is the pain in the child which is not being addressed, and he has come to you with pain. Now, how many times do we see toxic shock syndrome without fever? That is what is my question.
Sir, if in a case of a streptococcal toxic shock syndrome, it can present without
Yes. So
fever,
there are
sir.
situations where toxic shock syndrome might present without fever, right? So
Yes.
I think I would like to put this as the first possibility, with the history what you have presented and the examination what you have given to me,
Yes.
right? And certainly I would also not rule out drug-induced rashes at this stage. I would want to keep that also one of the possibilities, important possibilities, subject to the further investigations. So
Yes.
now we need to plan the investigations. So what are the investigations which were done to this child?
Yes, sir.
Dr. Suresh, I'm not keeping the tab on time. So please check me wherever we want to expedite or we want to cut it short.
Okay. Sir, these were the investigations that were done, sir. So 24th and 26th, these were the investigations that were done outside, and from 27th was done from our hospital, sir. Sir, outside also, the child had a high TLC count of 18,300 with a differential of 96% neutrophils and 3% of lymphocytes, sir. When the child presented to us, the child had a TLC count of 15,000 with a neutrophil of 62 and a lymphocyte of 30%, sir. But the child's platelet count has been dropped by the time the child presented to us from 3 lakh on 24 to 42,000 at Gangaram Hospital, sir. The child also, the BUN was also 62 on 26th, and when he came to us, it was around 31.6. So we can assume that the child might have episode of dehydration outside on 26th.
Yes, there is evidence the blood urine nitrogen was 62 and creatinine was 1.1 over there on
Yes, sir.
26th of May. So that was probably taken care of. That was a cause of, this
Altered
he went
sensorium.
into hypotensive situation over there and had altered sensorium, which was corrected over there. They pushed in fluids, and after that, the child recovered because the setting was of a hypovolemic situation. So it was a AKI also.
Yes, sir. And the sodium and potassium that was done at our hospital was 143 and 3.53. CRP done was 224 on the day of admission, and the procal of 180. So that also goes in favor of a bacterial possibility.
So basically telling you a severe inflammatory process is set in.
Yes, sir. Sir, we also did ammonia because of the episode of altered sensorium that was normal at our hospital. There was also a little episode of like transaminitis was also present with the SGOT of 202 and SGPT of 67, sir.
So here OT is more than PT.
Yes, sir.
So what does that mean?
Sir, sir, it's the
So if PT is more than OT, then probably these enzymes are coming from the liver.
liver.
But if OT is more than the PT, OT has many other sources, which include the skeletal muscle and the cardiac muscles also. So that means here the enzymes are coming from the skeletal muscle as well as the cardiac muscles. That is what I was saying. This child was having muscular pain and that's why he was irritable. And SGOT is helping you to make that understanding. And you can see the previous reports also 263 and 231, which were done before coming to your place. The SGOT was raised even at that time. So the muscular damage had set in at that stage.
Yes, sir.
Right.
The other investigations that were done, the infective workup was for malaria, leptospira, scrub, and dengue was done, which was negative. We have done a stool biofire, but that showed giardia, but the stool culture was negative.
So as we discussed that this giardia, this was an unrelated event. Diarrhea was probably unrelated, and maybe giardia would have been the cause. So
Yes,
what was this stool biofire? This stool biofire, does it differentiate between a giardia cyst and a giardia trophozoite? Because a giardia cyst
no,
may be
sir.
normally present in many
Yes.
stools, but a giardia trophozoite is the culprit.
Sir, no, sir, it does not differentiate between cyst and the trophozoite.
So we do not know whether this was the cause.
Okay, sir. Sir, we have done ferritin, which was 485, not very high.
Yeah.
And LDH was 682 with a fibrinogen of 1.9.
Approaching 500. Okay.
Approaching. Yes, sir. Sir, we have done a respiratory biofire also for him, which showed presence of adenovirus in this child. We have done an ultrasound whole abdomen, which showed gallbladder wall thickened and edematous. Bilateral kidney shows mild increase in echogenicity with a mild free fluid in abdomen.
So
And a
that we have
multiple
already discussed. This child had AKI.
pre-renal
This child had AKI, acute kidney injury, and this was reflecting in the ultrasound abdomen. So adenoviruses, do we also have a quantitative assessment of adenovirus numbers over here? Because
Yes, sir.
how do you connect this adenovirus with this kind of an illness?
Yes, sir. Actually, sir, initially when we did it was the biofire came positive. Then we sent a PCR also for adenovirus, sir. But that came out to be not in the detectable range.
Okay, so this is a false alarm, probably a false signal adenovirus, respiratory biofire, maybe a contamination. I don't know.
Yes, sir.
So adenovirus was not detected in the PCR. That is what
sir,
you're
yes,
saying.
sir. Yes, sir. Afterwards, sir.
Okay.
Then, sir, we have done a blood culture, blood culture also came negative. We have done a sputum culture also for him, and there was a stool culture, as I already told, was negative, sir. We have done a 2D echo to see the cardiac things, sir. There was no coronary dilation, and the ejection fraction also was normal, sir. Overall, the 2D echo was normal, sir. We have done fundus for him that showed mild disc pallor and bilateral lines. These were all the investigations that were done at the time.
So now, can you narrow down your diagnosis?
Yes, sir. Sir, it goes more toward the infective or inflammatory process, sir, since the CRP and procal is so high, sir. And also the platelet count is so the child is having an infective process, sir. And so it goes more towards the toxic shock syndrome that we were discussing, sir. And since it also affects multi-organ dysfunction, so that's why there was also the renal involvement also along with the little transaminitis and the altered sensorium part could be explained either with this or by the dehydration part, sir. That is also going in favor of the toxic shock syndrome, sir.
Okay, right.
So,
So
sir,
what
yes, sir.
what is your plan of treatment for this child?
Yes, sir. Sir, actually, we initially started the child on IV antibiotics and was given supportive treatment, sir. But as this thing, sir, as the child was shifted to the PICU, and then after shifting, sir, the child had on arterial blood pressure monitoring, the child had low blood pressure, sir, and the child had to be taken on inotropes, and the child had to be intubated, sir, and the child was not improving with the antibiotics, sir. So we had to give IVIG to the child, sir, at 2 gram per kg, sir.
Was a
And
chest X-ray done in this child?
uh, yes, sir, it was done, sir, but it did not show any significant changes, sir. But we had to intubate the child because the child was going into shock, and uh,
What was the heart size?
uh, sir, the heart size was normal, sir. I have no picture of the X-ray, sir. Sorry, but
Okay,
the child
ठीक है.
X-ray was normal, sir.
That would have been helpful. That
Yes, sir.
contributed to the discussions. Okay. Anyways, ठीक है. आगे चलिए.
Yes. So, sir, the child was started on IVIG, sir, and within the antibiotics were also upgraded, sir. But within 2 days of giving IVIG and high-grade antibiotics, the child improved, sir. The child was extubated within 2 days, sir. And
What was the first line IV antibiotics which were used?
yes, sir. Sir,
What
initially,
would you what अब जो हमने अभी डिस्कशन किया है इसमें अब हमें क्या फर्स्ट लाइन क्या यूज करना चाहिए इसके अंदर?
sir, we should have used initially, sir, since the child was uh, third generation cephalosporins should have been started, sir. Uh, but since the child was going into shock, sir, we started with meropenem and teicoplanin in this uh, child initially, sir.
So if you think that toxic shock syndrome is number one possibility in this particular case, so toxic shock syndrome के organisms कौन से होते हैं?
Yes, sir. Sir, Staphylococcus and Streptococcus and sir, Pseudomonas can also cause toxic shock
So we need to cover
syndrome.
gram-positive as well as gram-negative organisms, and gram-positive is Staphylococcus and Streptococcus are two main culprits, the
Yes, sir.
commonest of the all. And then rarely in immunocompromised and rare situations, you can have hospital-acquired situations, you can have gram-negative also, right?
Yes, sir.
So we need to cover those things also. So what is the strategy for toxic shock syndrome? I'm talking about antimicrobial strategy.
Yes, sir. Sir, initially, as written, sir, we have to start them on, sir, oxacillin, but it's not available, sir. So we start them on first generation cephalosporin, sir. And we have to upgrade the antibiotics and add clindamycin also to cover for the
To cover?
staff and sir, to remove the exotoxin that was produced, to remove
Yes,
the exotoxins.
clindamycin's role is very important because it prevents the toxins, the
Yes,
multiplication of toxins. So that is where the clindamycin works. It blocks the toxin release. So that is the important role of clindamycin. So clindamycin is not being used as an antimicrobial; it is being used there as an antitoxic agent. So one you use the antimicrobials for Staphylococcus and Streptococcus. Plus, this sick child like this, you can also start with a gram-negative cover. Also, you've rightly chosen meropenem over here, but you have to take care of the Staphylococcus also properly because and plus clindamycin also should be added, and you've added teicoplanin over here. That is a good cover for streptococcus, and then clindamycin also should be planned, and then you have to monitor, and as per requirements you have to manage.
yes, sir.
Okay, so here you started with meropenem and
Teicoplanin.
teicoplanin, and what were then you have mentioned you have upgraded. So what was the upgradation?
No, sir, we have added clindamycin
Okay,
to the
added
first.
cleanup. Good.
Yes, sir.
So that's excellent. Right.
Yes, sir. And sir, IVIG also helps in case of toxic shock syndrome. It
Yeah,
also the super
that's
antigen.
a add-on therapy, and it's a supportive treatment, and it does help you. Wonderful. Right.
Yes, sir. So
So,
child improved very free.
yeah, any side effects of IVIG which you want the other colleagues to understand and learn from you at this stage,
Yes, sir.
which
Sir,
you probably noticed in this particular child? Did you notice any side effects of IVIG?
sir, hemolytic anemia is one of the side effects of
What are the
IVIG or
common side
hypo,
effects of IVIG जो
sir,
सबसे ज्यादा common होते हैं?
hypotension and febrile reaction, sir. But
Yes,
hypotension,
febrile reactions are
headache,
number one. Number two,
sir, headache and hypotension is
headache and aseptic meningitis.
aseptic meningitis. Yes.
Aseptic meningitis, headache and vomitings.
Yes, sir.
So did your child did this child have any of these features, any of these side effects of IVIG?
No, sir. We did
Okay,
not have.
you are very fortunate. Wonderful.
Yes.
ठीक है. ठीक है, over to you, Dr. Suresh. Dr. Suresh, are you there?
Oh, I was muted actually.
Okay.
I was speaking, but nobody was able to. Dr. Neza has covered almost everything from history to examination to management. Right? And these learnings are very important for all the PGs. And we are very thankful to Dr. Neja for moderating this session on a very, very important topic on septic shock, toxic shock, and their differential diagnosis. If some candidate has some queries, they can ask us. Dr. Neja is there, myself is there, and Rishabh is also there. I can't see any question in the chat box. And today somehow attendance is also little less. I don't know the reason, maybe election result are people are busy in enjoying the election result and the discussions. That may be the reason.
So this election is a celebration time for everyone. So everyone is celebrating.
Everyone is celebrating. Everybody is a winner and
Irrespective,
everybody is loser.
yeah, irrespective of the alliances and affiliations, everyone is winning.
Everyone is winning. So, should we close?
Yeah, if there are no further questions or no further queries or no further comments, then probably yes.
There is a one question. Any role of steroids? Rishabh?
Yes, sir. Since the child has such an infective course initially, so first we had to cover the infective part before starting any steroids in this patient, sir. But sir, if the child wouldn't have improved with IVIG or um, still like the super antigen thing with the toxic shock syndrome, I don't know if the steroids would help.
Dr. Neja, any comment from your side?
So I think steroids, as our teachers used to say, whenever there is a confusion, you may start steroids. Whenever you're not heading anywhere else, you may start steroids. So that's an old time teaching. But currently, what we understand is steroids would flare up infections, especially when you're dealing with the active infections. Unless you control the infections, आपको इन्फ्लेमेशन कंट्रोल करने के लिए स्टेरॉइड्स यूज करना पड़ता है. So यहाँ what we have chosen is IVIG. So IVIG also practically controls the inflammation. So if IVIG is successful, then probably role of steroids would not be there. Yes, if there were coronary involvements, if there were evidences of coronary artery dilatations, then probably the current thinking is we should start both steroid as well as IVIG. So that is one area where we start both of them, both the things together. But otherwise, I think we should go sequentially and step by step. And steroids should be used only when we know that infection is totally under control and it is only the inflammatory process which is not disturbing the child and belly of the child, then we may use steroids in monitored doses, in very closely watching the development of the child. Then you can use steroids, but not otherwise. I think that is my understanding, and Suresh can add more to this.
That is absolutely true, as Dr. Taneja discussed. There are only very few situations in septic shock where you use steroids. So any condition which leads to adrenal suppression, right, there you can use. And that condition will be like meningococcemia. Meningococcemia, septic shock, that is a definite indication using for steroids. Then any child who is...
There we call it as Waterhouse-Friderichsen syndrome, where the adrenals are, they are damaged because of hemorrhages. There's a hemorrhagic necrosis of adrenals. So the child goes into what you call as a steroid depletion state, and where you have to supplement steroids to save the child. That is one situation where you do use it in the active infective process also.
Any child who was on steroid, right, who is on steroid, of course, you will continue the steroid. In that case, maybe you have to be little more loading dose also, right? And any child who has got steroid deficiency, like for Addison disease, like he develops septic shock, then because the adrenal glands cannot respond, so we have to give extra stress dose in those cases. And sometime when the patient is refractory to multiple inotropes, and we think that there may be some adrenal suppression, in severe cases of shock, sometimes we use very low dose of steroid also. But even in those situations, role is quite controversial whether that is beneficial or not. I think if everything is answered, we can.
Yes, I think. Yeah, I think. Thank you, Dr. Suresh, for inviting me over here today with this wonderful audience and the wonderful case that was presented by Dr. Rishabh. Thank you very much.
Thank you, sir.
Dr. Taneja, for sparing your valuable time and your input. It was very, very lively discussion.
It was always pleasurable to be with you, Suresh. We have been together since your PG days in Safdarjung Hospital.
And I still remember you used to teach us a lot, actually, how to do lumbar puncture in children, and in the middle of the night, and you take us, okay, Suresh, you do it this LP. I'm standing, don't worry, you can do it. So he was he's a great teacher, actually, and very encouraging, I must say.
Thank you, Dr. Suresh. Thank you.
Okay.
Thank you, everyone.
Thank you, Rishabh. Thank you, all the participants. Okay.
Thank you, sir.
So we can close now.
Okay.